Welcome to part 5 of aging. This PowerPoint is going to focus on vision changes in the older adult. The sense of vision is a very powerful sense for us. Vision shows us the world. Vision shows us our loved ones and our friends. So when a person develops vision issues, it can be life-altering. Before we discuss vision changes, let's discuss the eye and how vision works. The eyes are front and center on our face, and because of that, they're easy to assess. Our eyeball, or the globe, sits inside of the eye socket, which is technically called the orbit. The eye socket is surrounded by our sinuses, bone, muscles that help the eyeball move around, and connective tissue. There's also some adipose tissue in there as well. Coming from our brain, connected to the eyeball, is the optic nerve alongside the ophthalmic artery to give the eyeball blood. Protecting the eyeball are our eyelids, which open and close by smooth muscles. There are also lacrimal glands that produce our tears to lubricate the eyeball. We have eyelashes to keep foreign bodies and dust out of our eyes. The lashes keep out the bigger objects, and the tiny things that do get through get washed away by our tears with every blink of our eyes. There's a thin membrane that's a barrier to keep the eyeball in and protected from the outside, and that's our conjunctiva. It covers the inside of the eyeballs, and it goes up over the sclera and stops right around the cornea. The eyeballs are made up of 3 layers. The outermost layer is a dense fibrous layer that has our sclera and our cornea. The middle layer is our vascular layer, and it has our iris, or that colored part of our eyeball. The inner layer is our neural layer, and that's where our retina, optic nerve, and our visual pathway is. The eyeball is also filled with fluid. The most important, in my opinion, fluid in our eyeball is the aqueous humor, which gives the eyeball its shape and also controls the intraocular pressure. Think of this as the blood pressure in the eyeball. This will be important when we discuss some vision disorders that actually affect the intraocular pressure. The pupil can constrict and dilate in response to light, and it's controlled by muscles in the iris. The muscles are controlled by our sympathetic and parasympathetic nervous system. Directly behind the pupil and the iris is a lens that helps us see. The lens helps us focus on what we're looking at so we can see it. Behind all of this, we have the retina, which is part of the optic nerve, and there's a part of the retina called the macula, which controls our central vision. This is important for another vision disorder we will discuss. The optic nerve connects directly to our brain and transmits what we see to our brain so it can be processed as an image. There are diseases that can affect the optic nerve itself also that you're going to learn about in later blocks. Nurses do not do a full eye exam like an ophthalmologist would do. An ophthalmologist is going to go into in-depth assessment of the eyes, like looking at the intraocular pressures and visual acuity and color testing, and many more things a nurse wouldn't do. However, there are things nurses do to assess, and some nurses, like school nurses, may do more assessment than hospital nurses would. As nurses, we should be looking at the external eye. We assess the pupil size and reaction. Remember Perla from way back in weeks 1 and week 2? We were assessing the eyes. We also assess the sclera and the conjunctiva for redness or swelling or color changes and even discharge. We checked accommodation and eye movements. And all of those things that we checked are very important. As you move through the diseases and your patients get sicker and sicker, those things we learned about at the beginning will be very important to help you diagnose disorders later on. Those are very important skills for you to have that you've already learned. In addition to these assessments, we may need to ask our patients about their eye health and if they use any corrective devices for their vision, like glasses or corrective lenses. I mentioned school nurses. Most school nurses do check for vision acuity using a Snellen chart, which is that letter chart where the letters get smaller and smaller. School nurses check vision in students and then let their parents know if they think their child needs to go see an eye doctor. Not every school has a school nurse, but if they do, they're going to check their vision. The Snellen chart helps ophthalmologists rate how well a person can see from 20 feet away. Perfect vision would mean that you can read line 8 on that little picture above from 20 feet away. If they can see smaller than that, that's awesome. If they can't see that small and maybe they can see line 7 or 6, they have some vision impairment. Let's move on to our first vision disorder, which is impaired vision caused by refractive errors. These are the most common types of vision issues, and they're not specific to old age. People of any age can have impaired vision caused by refractive errors. With refractive errors, there's an eyeball shape change that makes it hard to see clearly because the light rays are not being focused sharply on the retina by that lens. A normal shaped eyeball causes no vision issues, and that's called emmetropia. They have perfect vision, and we would say that they had 20/20 vision if we saw an ophthalmologist. If the eyeball is too deep, that means the person has myopia, which is nearsightedness. They can't see far away. If the eyeball is too shallow, we have hyperopia, which is farsightedness, meaning they can't see close up. Thankfully, these refractive errors can be fixed with glasses, corrective lenses, and even surgery. Another common type of eyeball shape issue that causes vision impairment is an astigmatism, and that is caused by an irregularly shaped cornea. If a person has such bad vision that they can't see the big E on that Snellen chart, they would have 20/200 vision, and that's classified as legally blind if they can't see that with correction. So if they can't see that big E and the doctor has done everything they could to get them to see that big E, they would be considered legally blind. Absolute blindness would be that the person has no light perception at all. Legally blind is a disability, and there are governments that will give people disability assistance for being legally blind. Living with low vision can be as simple as wearing glasses or corrective lenses, all the way to needing alternative methods for communication and ambulation. Thankfully, so many options are available to help people with low vision. If the low vision is new or unexpected, there may be some coping and grief issues that we may need to address to help the patient get through it. Kids who get glasses may not want to wear the glasses and may be bullied for wearing them. And there's an appearance change with glasses, so there's a lot of emotional processing that we may need to help our patients with. If our patients wear glasses or contacts, we want to make sure they wear them. If they don't have them, we need to adjust the environment to make it easier for them to see. We need to be strategic with where we place objects in the room and try to stay consistent. Things like the call bell, water cups, and food trays need to be placed within reach, and we need to explain where everything is. We may need to announce our presence when we enter the room and when we leave, so the person knows where someone is if no one's there. We need to make sure the room and the floor is clear, and we need to assist them with ambulation. We should also explain everything that we're going to be doing to the patient, especially if we're going to be touching them. We should make sure we tell them that we're going to touch them. They need to know that before we do it. We may need to get physical and occupational therapy in to help the patient be stronger and safer with ambulation and their ADLs. And we may even need to print their education out with the largest font print we have, or even find Braille or devices that read out loud to them. In some cases, a person may qualify for a service animal to help guide them with ambulation and their care. These animals are an extension of the person's sense of vision, so the animals stay by their side at almost all times. The next vision disorder we're going to discuss is glaucoma. Glaucoma is a group of ocular conditions where there is damage to the optic nerve because there is high intraocular pressure caused by congestion or too much aqueous humor in the eyeball. The damage can be mechanical damage, like physical damage to the nerve, or it can be ischemic, meaning loss of oxygen and the nerve cells die. This is going to cause vision loss. Glaucoma affects 3 million Americans, mostly aged 40 years and older, and it's the third most common age-related eye disease in America. There is no cure for it. We do have treatments to control it though. There are several different types of glaucoma, with wide angle and open angle being the most common. The wide versus open angle relates to where the spot in the eyebrow where the aqueous humor is not draining from properly. There's a lot more to that, but just know that there are different types. Diseases like sleep apnea, diabetes, cardiovascular disease, and being older puts everyone at risk for glaucoma. Glaucoma is called the silent thief of sight because most patients are unaware that they have the disease until they have vision changes and vision loss. They may have blurred vision, halos around lights, difficulty focusing, difficulty seeing in low lighting, loss of peripheral vision, and achy eyes. And they may also have headaches. An ophthalmologist takes pressure readings of the eyeballs called tonometry and does an ophthalmoscopy to inspect the optic nerve disc. Other than nurses relaying the symptoms to the provider, there really isn't a way for nurses to assess glaucoma because this really is an ophthalmologist thing. The goal of managing glaucoma is to prevent further damage to the optic nerve. This isn't a one-time treatment. This is everyday for life treatment. We need to get the intraocular pressure down and keep it down so it doesn't damage the optic nerve. We can do this with special eye drops that decrease the pressure in the eyeball. There are different types of eye drops and they all work a little differently. Miotic eye drops work to constrict the pupil and open up the fluid framework in the eyeball to reduce the pressure. Beta blocker eye drops, which are the treatment of choice, decrease production of aqueous humor, as do alpha-2 agonist and carbonic anhydrase inhibitors. Prostaglandin analogs help increase the outflow of the fluid from the eyeball. These eye drops are not without side effects and they may get absorbed into the bloodstream. Think of those beta blocker eye drops. If they get absorbed, what beta blocker action side effects might we see? Lower heart rate, lower blood pressure. To help stop these side effects, we need to hold pressure on the inner canthus of the eye, which is the inner point next to the nose, so the drugs don't get absorbed into the tear troughs and get absorbed systemically. If the eye drops do not work, there is surgery that can be done to improve the fluid drainage from the eyeball, making a tiny little incision. There's even a laser treatment to laser little holes to make the fluid drain and the pressure go down. They only go to these options if the eye drops don't work. In addition to assessing for glaucoma and administering glaucoma medications, nurses need to assess for knowledge level and adherence of the disease and the treatments. They also need to be educated about these things and how to care for themselves with their limited vision. This is a lifelong condition, so they have to follow the treatment plan if they want to retain the vision they have left. This means we need to provide education regarding the use and effects of the medications and what will happen if they stop taking the medications. This includes side effects and how to manage the side effects, especially if vision alterations occur from the side effects. We also need to provide support and interventions to aid the patients to adjust to the vision loss or potential vision loss. Losing a sense is very distressing and anxiety provoking, and a lot of emotional support may be needed. The next vision disorder we're going to discuss is cataracts. Cataracts is when the lens in the eyeball becomes opaque or cloudy, like this picture. Cataracts affects 18 million people worldwide, and it even affects our pets. Cataracts are the leading cause of blindness in the world and is a leading cause of disability in America. It can occur at any age in one or both eyes, but it's very common after the age of 80, when over half of Americans 80 and older will have cataracts. Age is the biggest risk factor for cataracts. Infection, toxic chemicals, obesity, and eye trauma are also risk factors. Painless, blurry vision is the characteristic sign of cataracts. The person may say things look dimmer, as if they have dirty glasses on that need to be cleaned. They may have sensitivity to light glares and reduced visual acuity. Things just look blurry and fuzzy. They may develop myopia, astigmatisms, and diplopia, which is double vision. Colors may start changing to have a brownish hue, and the ophthalmologist is going to assess decreased visual acuity, and they're going to see that their lens on their eye has turned opaque when they use that ophthalmoscope. Unfortunately, there's no non-surgical treatment. Doctors will watch the cataracts, and as long as it's not interfering with normal activities, they will not do anything for it. Once it becomes an issue with being able to function normally, they will surgically remove the cataracts. This is a pretty easy and fast outpatient procedure where they cut off the opaque lens. After it's removed, they need a lens, and the options are to have special glasses, contact lenses, or an implanted intraocular lens. The most common is that implanted intraocular lens. Glasses and contacts have to be removed, and they don't provide full vision coverage, so they don't have the best vision. The intraocular lenses are most like their natural lenses and have the best results. There are some complications like hemorrhage, bacterial infections in the eyes, and malposition of the intraocular lens. Since the only treatment for cataracts is surgical, the care nurses provide is going to surround that surgery. We don't discuss surgery in Block 1, but most of it's going to surround the perioperative assessments and vital signs and any complications to the surgery. But what we will do as all nurses is include education on eye drops they might be prescribed and complications to watch out for, and if it's recently after surgery, when to call the surgeon. These post-op complications may include vision changes, flashing lights appearing, redness, swelling, drainage, and significant eye pain that's not being controlled by acetaminophen. The last vision disorder we're going to discuss is age-related macular degeneration, or AMD. AMD is the leading cause of irreversible blindness and vision impairment in the world. AMD occurs when there is clusters of waste products and debris called drusen beneath the macula area of the retina. These drusen cause central vision loss, but peripheral vision stays intact. Some people may have total blindness, but only a small amount of people. There are two types of AMD, wet and dry. 85 to 90% of people will have the dry type of AMD. The outermost layers of the retina break down, which cause those drusen. They have gradual central blurring of their vision, which seems to be the most noticeable when the person tries to read. The wet type of AMD occurs abruptly and occurs when abnormal blood vessels grow under the retina and leak fluid, elevating that retina from its normal position. Some of these patients may have the leakage stopped with laser therapy. And here's a picture of what people with AMD see every day. They can't see the center of their vision fields, but they can still see the peripheral vision fields. Unfortunately, there are no treatments for dry AMD. Wet AMD does have some treatments where intravitreal injections of medications are used to stop the abnormal blood vessel growth. If you can't tell by the term intravitreal injections, that means injections into the eyeball. And that's all there is to help wet AMD. All we can try to do is help them function with the loss of their central vision fields. This could be by placing all of their belongings to the side of their trays, putting the TV to the side of their face, or even turning the bed so that they can see the sides of the room better. We can also educate the patient on the best ways to ambulate and perform ADLs, which may require the help of physical therapy and occupational therapy, and we need to educate them not to drive. They need to test their vision several times a week by looking at a grid or boxes or whatever their ophthalmologist wants them to look at to see if their vision is worsening. And this is the end of part 5 of vision changes.